Thank you very much. I will be taking this forward, looking at the signal in question 3 to 5. After that, providing a couple of examples and then move on to questions. So, the question of relating to signal in question 3 to 5 has to do with differential misclassification or differential measurement errors, and can be reformulated as basically to do with who is assessing the outcome, whether the outcome assessor is blinded to the intervention assignment or not, and whether that makes a difference, whether the assessment is likely to be influenced by a knowledge of intervention assignment. That latter part is something new in the previous version of the tool. It's more a question of blinding or not blinding, and we'll move on to actually reflecting on whether those special situations where we think blinding is not so important. So, it's important to reflect on the concept of outcome assessor. Obviously, most would think that an outcome assessor is an observer who is not directly involved in the intervention and who is assessing an event, for example, whether an arm is fractured or not. However, there are two different situations where the outcome assessor is not an observer. The most important thing is when the outcome assessor is the participant or the patient in the many trials and many important trials with patient or participant reported outcomes. So in that situation, the patient or the participant is the outcome assessor. In rarer cases, the outcome assessor can be the intervention provider. That is, for example, a physician who makes a therapeutical decision. That could be to offer a surgical intervention or to discharge a patient from the hospital or transferring a patient from the intensive care unit. In that situation, the outcome assessor is the intervention provider. So it's very central when we assess risk of bias using ROB2 that we're aware of which function, which person is intended, are we talking about as the outcome assessor. In many cases, it'll be an observer. In also many cases, it'll be the patient, and sometimes it will be the intervention provider. So, just a few notes about blinding and reporting. Reporting of blinding issues in trials is inadequate in many cases. I've taken out a study of 200 trial reports showing that among these 200 trial reports, among the papers that reported blinding as double blind, that in a quarter of those, double blind was the only term used to describe blinding. So obviously that makes assessment or detailed assessment of the risk of bias difficult, and it's important in those cases to go on and to try to figure out where there is more information, obviously in protocols, for example, and there has to be a trade-off between how far you go down the trail to get more information. But it is a challenge for everyone doing risk of bias assessment that the reporting of very central issues is inadequate, especially in older trials and especially in trials not adhering to the consort statement. So let's go on to signal in question 4.3. this signaling question basically asks whether the outcome assessor was blinded or not. Was the outcome assessor aware of the intervention received by study participants? And it's probably a good idea to think about this question as having two components. One is that the outcome assessor was intended to be blind, and the second was whether that intention was successful. So let's move on to the first component. Often, or not that often, but sometimes this is fairly well described. For example, outcome assessors were blinded, and it's implicit in the trial report who the outcome assessor was. Non-blind participants and blind outcome assessors. These makes it fairly clear that there was an intention to blind outcome assessors. We're moving slightly into a gray zone with trials where there are double-blind drug trials, but with no indication of lack of blinding of outcome assessors and with a clear description of how blinding was achieved. I would say that would be okay, but we can debate that. Obviously, a red flag or a problematic thing is when reporting the only thing that we know is that a trial was single-blind or even double-blind, especially in a non-pharmacological setting, or when there are external assessors that are not involved in patient care, but blinding is not mentioned explicitly. A special case is when there are blind assessor interviewing non-blind patients. In the context of ROB2, that is the outcome assessor in this situation is not the blind interviewer, but the patients, and should be regarded as a problematic situation. So that was the first component of that signaling question. The second component was whether blinding of outcome assessor is successful. It's probably less important than if blinding was intended theoretically, in that it's a rare case that all patients or participants have been unblinded, but obviously that will occur. The reporting of the success of blinding is even worse than the reporting of blinding. However, a green flag would be that if pre-trial testing of matching of compared interventions have been reported, that is good. If there is an interaction between an assessor, a blinded assessor, and non-blind patients, and there is a description of procedures to handle cases of accidental unblinding, that is good. And obviously, if there are no telltale effects of the intervention, that is also good. Red flags would be if there is no procedures described to handle accidental unblinding, if there are telltale effects. Isabel previously talked about the well-known example of the zinc aftertaste. This requires quite considerable content knowledge within trials in the field, but obviously it is probably more often than we would like to think, a problem. Run-in periods where patients receive active or placebo treatment, and then in half of the cases when the trial really starts, shift to either active or placebo, will resemble in that context a crossover trial, so patients have direct comparison of active and placebo interventions, so even minute or smaller differences or mismatch between the two types of interventions will more easily be noticed. So to broadly answer this question requires quite a detailed knowledge, and it's one of these questions where access to protocol or access to trial lists would be valuable. Okay, let's move on to the signal question 4.4. Good assessment of the influence by knowledge of intervention. So basically, this is not a question of blinding or not blinding, but whether blinding matters or not. And we think that there is a clear case for that objective outcomes are robust to lack of blinding, especially all-case mortality, and also some automated test procedures, laboratory measurements, preferably laboratory measurements that are non-repeatable, would be regarded as objective outcomes, and even in trials that are not blinded, those would be okay. So it's probably important to reflect on what we mean by subjective and objective outcomes, and in general, because the two signaling questions coming up now have to do with interaction between the type of outcome and the whether or not outcome assessors have equilibrium or not. So subjective outcomes are basically in context of RUB2 outcomes involving judgment. We could think of that as outcomes with moderate to high inter-observer variation, whereas objective outcomes are those involving very small or no judgment, no or low inter-observer variation. The terms are used differently in other contexts. Sometimes subjective outcomes would be regarded as observer-reported, and subjective outcome would be something that is a sentiment or a feeling that is inherently private to a person, but these are not the ways the terms are used in RUB2. So a model for observer bias basically could be seen as an interaction between the preconceptions of the observer and the subjectivity of the outcome, and this could be illustrated with the famous 2010 World Cup game between England and Germany. Lampard shot. England was trailing Germany 1-2. Is there a goal or not? And those that look at the ball would just be unclear whether there was a goal or not. The referee said there was not a goal. When you look at it in a different angle, there clearly was a goal. The important thing here is that the referee is a neutral observer, and the fans of England, the German fans, and the English fans would tend clearly to interpret this subjective outcome differently. So signal question 4-5 moves on. Here we're not talking about whether there's an outcome robust to lack of blinding, but whether blinding, even in outcomes that are subjective, matters or not. This is a new element of the tool, and it boils down to whether it is likely that observers would have been influenced by a lack of blinding. And the considerations here is on the trial context, on the preconceptions, hopes, hunches, and conflicts of interest of the observers. It's also important to note that the reply to this question has to do with differentiating between low risk or high risk of bias and some concerns, not whether there's low risk of bias. Red flag for high risk of bias, obviously, or could be that there's the experimental intervention is compared with a no treatment or a usual care control group and not with another active treatment or a placebo. Outcome assessors are strongly engaged in other parts of the trial and are not brought in just for the case of doing an assessment. And outcomes with a high degree of subjectivity, possibly also conflicts of interest. And just to inform you that we're working on a tool to address conflicts of interest in trials that will inform these signaling questions. Some concerns would be if there's an active control group where the external outcome assessor is brought in, not otherwise engaged in the trial, and if there's an outcome with which is subjective, but still within a low degree of outcome subjectivity. So this is the algorithm. Low risk of bias basically boils down to whether is there an outcome assessor, are the outcome assessor blinded, and if it's not blinded, is the outcome objective, and various combination of this will then end up with some concerns or high risk of bias. So challenging, obviously, the blinding terminology we talked about. It's important to look for direct descriptions of blinding and not only rely on terms that are double blind or single blind. Reporting of blinding is often inadequate, and probably it's wise to look for supplementary sources of information, preferably the protocol, or even contacting authors. And it's just a basic thing that ROB2 involves judgment based on imperfect information. Example would be a trial by Hannah Arrow. 277 patients were randomized to usual care plus a human bone morphogenetic protein versus usual care. And the information in the trial was that this was a multi-center, single-blind randomized study. When you read the paper, it's not clear who that single-blinded person is. The outcome, though, is healed fracture, and they reflect in the discussion that it wasn't possible to blind the investigator. And when you look at the outcome, there wasn't a statistically significant effect based on the reported odds ratio, the reported effect by the non-blinded surgeons, but the point estimate indicated the possible effect. What they didn't report was the effect based on the blinded radiologists that were not reported in the paper, indicating a possible harm effect with an odds ratio point estimate of 1.23. So an example of a trial with inadequate reporting. Another example in which the patient is the outcome assessor is Barrett's impressive trial in Annals of Internal Medicine with over 700 patients randomized to echinacea tablets or extracts versus placebo. An extract of the nice flower you can see there. And they report very nicely that there were placebo pills blinded and echinacea pills also blinded. The trial was unusual in the sense that there were four groups. There were also patients that received no pills and patient that receives echinacea pills unblinded, open label. So that enabled a very a nice direct randomized comparison whether blinding of patients in this situation matters. The reporting of the placebo and echinacea tablets was fairly okay. Identical digestible coatings. They reported the outcome, which was by self-report. And you can see that the result of comparison directly, the blinded and the unblinded effect estimate was standardized mean difference of roughly 0.12, and there was we identified a number of such studies published in 2014. So the blinding of the patient when the patient is the outcome assessor seems to be quite important. So, in conclusion, it's important to differentiate between trials with low and high risk of bias in measurement of the outcome, boiling down to differentiating low and high risk of bias, low risk of bias trials that have implemented blinding, unlikely that blinding could have been broken, and if there was no blinding, whether measurement had been influenced by knowledge of the intervention assignment, basically boiling down to whether the outcome was objective or not. High risk of bias when there is no blinding, broken blinding, and measurement likely to be influenced. So thank you to Miranda Campton, Julie Higgins, and Jonathan Stern, the Cochrane Bias Methods Group and the Australian Cochrane Centre for some of the slides that we worked on.